so we are talking about so when to go retrograde procedure. But I have only 5 minutes, so that I will skip something. Okay, this is a CTO PCI. Recently, nowadays, success rate is increasing about 85 to 90%. That is depend on the sort of refinement of equipment and the development of the technique, like I was guided, and I think that's a retrograde procedure. That is one big issue for that is a game changer of the CTO PCI. And now, recently, those are registry data from all over the world. About the procedure success rate is about 85 to 90%. And within them, about 20 to 40% cases are retrograde procedure. And when I perform a CTO procedure, JCTO score 0 and score 1 is not needed a retrograde procedure. However, the difficult one, JTC score 2 and score 3, it is more than 50% cases needed retrograde procedure. That means difficult CTO needs a retrograde procedure. And so this is the history of the retrograde CTO PCI. And but there is also some technique about the retrograde kissing warrior cut technique and the reverse cut technique. However, nowadays, almost retrograde is done by the reverse cut technique. That is shows more than 60% is reverse cut technique. And however, so there is a light and darkness of the retrograde procedure. The high success rate, especially composite CTO or Antegrade approach, is not technically feasible or fails. And within them, so when go retrograde, this is expert registry in Japan and also retrograde summit in Japan. That is also almost a similar situation. The expert registry includes more difficult CTO cases. In those, about 30% has temperatures primary retrograde procedure. Retrograde summit is included a junior operator. That's why so not so difficult. That's why so primary retrograde is about 40%. That means difficult CTO needs a retrograde. And so this is a global chronicle CTO algorithm. So for the junior operator, I think it is better to follow the algorithm. So when perform a retrograde procedure, there are proximal cap ambiguity and the poor visual quality and the Antegrade failed. Those 3 points is also timing to consider about retrograde procedure. I will show some cases. When proximal cap ambiguity, we usually check that IBUS guided puncture without a side branch at that time. Retrograde procedure, or maybe it's a United States physician is considered about move the cap, and at that time, which is better to consideration? I think so feasible retrograde option. There's channel collateral and also distance of the channel connection to the CTO exit and the angle of the distal lumen CTO exit. This 3 point is very important to consideration of a retrograde procedure. About the channel, this is a paper from Dr. Nagamatsu who mentioned about the vessel size and the continuous except the corkscrew. That means also A and B. A is longer than B, the distance is a little bit difficult to negotiate a guide warrior. And also reverse bend. Reverse bend is a guide warrior advanced to the coming to reverse side. That is a little bit difficult to negotiate a guide warrior. And the corkscrew. Those are so difficult point to negotiate a retrograde guide warrior. And so that is depend on those findings. We usually check the scoring, total score. And so 0 is easy to negotiate a guide warrior, and the immediate 1 or 2 is difficult, and the difficult 3. And the angle is also important. I will show one case. This is a LAD CTO. Of course, so IBUS guided wiring is also one option. However, this is CTO exit is very difficult to confirm. Very narrowing. That's why so we started with a retrograde approach. Easily advanced the retrograde guide wiring, and so I advanced the guide wire to diagonal branch, and that CTO length is short. That's why so retrograde wiring is started. And this is a directed wiring from the retrograde. And so the confirmation of the wire is inter-lumen or not, that is by IBUS is very important. If the guide wires go subintimal space and closer to the proximal, we will lose side diagonal. That's why IBUS guided is very important. This is a schema of that. And feasible retrograde is like this one, very long, and distal end is not so clear. In those situations, antegrade wiring is very difficult. That's why we started a retrograde approach and check the collateral, and so the case is ejection fraction is about 18. That's why we use impeller for the situation. And so rescue lateral. This is performed with young physicians, and antegrade wire failed. Parallel wire is also failed, and we use RV branch to LAD. And finally, retrograde is succeed. So this is a 3. Antegrade puncture is difficult. So to the retrograde rescue lateral, when we will change to the retrograde approach. This is a paper from the Japan. So more than 20 minutes of the antegrade wiring, it was frequently failed. And long procedure of the antegrade is associated with a visceral perforation like that. That's why, if we failed after 20 minutes of the antegrade wiring, it may be considering about retrograde to switch. So this is a 3-point proximal care permeability, and that's poor distal big quality, and antegrade wiring was failed. This is a 3-point to consider about the retrograde approach. Thank you for your attention.